You wake up at 3 a.m. again, and this time it's not your blood sugar that woke you. It's the pounding in your head, that pressure behind your eyes that makes you feel like your skull is in a vice. You reach for your blood pressure cuff, the one you keep on your nightstand now because you check it so often, and you watch those numbers climb. 152/88. Your doctor said it needs to be under 130/80 because you have diabetes. You take the extra pill like you were told to do when it's high. Then you lie back down, but you can't sleep because now you're worried. Worried about your heart. Worried about another stroke like the one your sister had. Worried about your kidneys because your doctor mentioned something about protein in your urine last visit. And worried because no matter how many pills you take, no matter how much salt you cut out, no matter how carefully you follow every instruction, your blood pressure still does this. What if I told you that the blood pressure target your doctor is pushing you toward, that 130/80 goal that's driving you to take more and more medications, might actually be increasing your risk of falling, of cognitive decline, of ending up in the hospital, and of dying sooner? What if I told you that brand new research published just 8 weeks ago in the Journal of the American Medical Association shows that for adults over 65 with diabetes, the aggressive blood pressure targets we've been using for the past decade might be doing more harm than good? I'm Dr. Robert Callahan, and I've spent the last 22 years as an endocrinologist and cardiologist specializing in the care of older adults with diabetes and heart disease. I've treated over 1,200 patients in this exact situation, and I'm going to tell you something today that might contradict everything your doctor has told you about blood pressure control. But I'm not going to tell you the exact numbers yet, because if I do, some of you will write them down, close this video, marching to your doctor's office tomorrow, and potentially put yourself at risk. You need to understand why first. You need to see what I've seen. You need to hear these stories. So before we go any further, I need to ask you something, and I want you to be completely honest. Comment below your current blood pressure goal, your age, and whether you have diabetes. Just like this. Goal, 130/80, age 72, diabetes. Or goal, 140/90, age 68, diabetes. That's it. No explanation needed. Because here's what I'm seeing in my practice. There's a massive gap between what the guidelines say and what's actually happening with real people. Your comment isn't just numbers to me. It's data that helps me understand what you're really dealing with. And when I see patterns in these comments, I make videos addressing exactly those situations. So comment your blood pressure goal, your age, and whether you have diabetes right now. You might feel like you're the only one struggling with these numbers, but I promise you, you're not alone. Let me tell you about Margaret Chen. She was 76 years old when I first met her in my office 3 years ago. Margaret had been living with type 2 diabetes for 14 years, and for most of that time, she managed pretty well. Her A1C hovered around 7.2%. She took metformin and a small dose of a medication called glipizide, and she walked every morning with her husband Tom in their neighborhood. Margaret was one of those patients who did everything right. She checked her blood sugar twice a day, she measured her portions, she kept a notebook where she tracked everything, her blood sugar readings, her blood pressure, her weight, even how she felt each day. At her annual physical in early 2021, her primary care doctor noticed her blood pressure was running a bit high, not dramatically high, but consistently in the 145/85 range. Her doctor, following the guidelines that had been updated a few years earlier, told Margaret that because she had diabetes, her blood pressure needed to be under 130/80. The doctor explained that high blood pressure combined with diabetes was especially dangerous for her heart, her kidneys, and her eyes. Margaret trusted her doctor completely, so she agreed to start taking a medication called lisinopril. The dose was small at first, just 5 milligrams once a day. A month later, her blood pressure was 138/82. Better, but not quite at goal. Her doctor increased the lisinopril to 10 milligrams. Another month passed. Blood pressure was 135/80. Getting closer, the doctor added a second medication, a water pill called hydrochlorothiazide. 2 months later, Margaret's blood pressure was 128/78. Perfect, right? Her doctor was pleased. The numbers looked great on paper. But Margaret didn't feel great. She felt tired all the time. She told me later that she thought it was just her age, just part of getting older, so she didn't mention it to her doctor. She started feeling dizzy when she stood up too quickly, so she learned to stand up slowly. She started having to get up 3 times a night to urinate because of the water pill, so she stopped drinking water after 6 p.m. She stopped going on her morning walks with Tom because she felt too lightheaded, especially in the first hour after taking her morning medications. But her blood pressure was at goal, so she thought she was doing the right thing. 6 months after starting the blood pressure medications, Margaret stood up from her couch one evening to answer the phone, and she fell. She didn't just stumble, she went down hard, hit her head on the corner of her coffee table, and lay on the floor confused and bleeding while Tom called 911. At the emergency room, her blood pressure was 98/60. The ER doctor asked what medication she was taking, and when Tom listed them, his face changed. He told them that Margaret's blood pressure had dropped too low when she stood up, a condition called orthostatic hypotension, and that's what caused her fall. The CT scan of her head showed a small brain bleed, what doctors call a subdural hematoma. Nothing massive, nothing that required surgery, but something that would need to be monitored carefully. Margaret spent 4 days in the hospital. The hospital doctors stopped one of her blood pressure medications. They told her to follow up with her primary care doctor in a week. But here's what happened next, and this is the part that still makes me angry 3 years later. When Margaret followed up with her primary care doctor, her blood pressure in the office was 142/84, and her doctor, concerned that she was no longer at the target blood pressure goal, wanted to restart the medication that the hospital had stopped. Tom, who had been quiet and supportive through all of this, finally spoke up. He asked the doctor if maybe the blood pressure medications had caused Margaret's fall. The doctor acknowledged that, yes, that was likely what happened, but explained that the risk of stroke and heart attack from uncontrolled blood pressure was greater than the risk of another fall. Margaret, who always followed doctor's orders, agreed to restart the medication at a lower dose. Over the next 8 months, Margaret fell 2 more times. Both times, her blood pressure was too low. Both times, she ended up in the emergency room. The second fall resulted in a fractured wrist. The third fall resulted in a compression fracture in her spine. After the third fall, Margaret stopped taking her blood pressure medications completely. She didn't tell her doctor, she just stopped. She was terrified of falling again. And this is when I finally met Margaret, because her primary care doctor referred her to me for help managing what he called her non-compliance with blood pressure treatment. When Margaret walked into my office with Tom by her side, I saw a woman who had aged 10 years in the span of 1. She moved slowly, carefully, like someone who no longer trusted her own body. She had lost 15 pounds because she was afraid to move around her kitchen. She had given up her morning walks completely. She had stopped going to her book club because she was embarrassed about needing Tom to help her up from chairs. Her blood pressure that day in my office was 148/86, and her first words to me, after I introduced myself, were, "I know my blood pressure is too high. I know I'm supposed to take the pills, but I'm more afraid of falling than I am of a heart attack." How can following doctor's orders, following the guidelines, following the blood pressure targets that are supposed to protect people with diabetes lead to this kind of deterioration in someone's quality of life and independence? Before we go further, I want you to know something. You're not alone in this struggle with diabetes and blood pressure. Every week on this channel, I share research-backed information that can change how you manage your blood sugar and your blood pressure. Information that often takes years to reach your doctor's office. If you've ever felt confused by conflicting advice or frustrated that no one explains why your numbers matter, this channel was created for you. Hit that subscribe button because you deserve to understand your own health. You deserve information that respects your intelligence and your experience. And I promise you, every video here is made with one goal: helping you live better, not just longer. Here's what's happening, and most doctors don't fully understand this because we weren't trained to think this way. We were trained to treat numbers. We were trained to follow guidelines. We were trained that lower blood pressure is always better, especially in people with diabetes. And for decades, that made sense based on the research we had. The landmark studies that shaped our current blood pressure guidelines, studies with names like Accord and Sprint, showed that intensive blood pressure control could reduce the risk of heart attacks and strokes. But here's the critical thing that got lost in translation. Those studies weren't actually studying people like Margaret. Let me explain what I mean. The Accord trial, which specifically looked at people with type 2 diabetes, compared intensive blood pressure control with a target under 120 systolic versus standard control with a target under 140 systolic. The study enrolled over 4,700 people with diabetes. Sounds perfect, right? Except the average age of participants was 62 years old. It excluded anyone with a history of recent falls. It excluded anyone with significant kidney disease. It excluded anyone who was frail or had mobility problems. In other words, it excluded exactly the kind of patients who end up in my office: older adults with multiple chronic conditions, people who are at high risk for the complications of aggressive blood pressure treatment. And even in that relatively healthy, younger population of people with diabetes, the intensive blood pressure control did not significantly reduce the risk of the primary outcome, which was a combination of heart attack, stroke, and cardiovascular death. It did reduce the risk of stroke by about 40%, which sounds impressive until you look at the absolute numbers. The stroke rate was 1.3% in the standard treatment group and 0.8% in the intensive treatment group over about 5 years. That's a difference of 0.5%, or one stroke prevented for every 200 people treated intensively for 5 years. Now let's look at the harms. Serious adverse events attributed to blood pressure medications were significantly higher in the intensive treatment group. We're talking about dangerously low blood pressure, kidney problems, low potassium, low sodium, and other complications. The rate of serious adverse events was 3.3% per year in the intensive group versus 1.3% per year in the standard group. So you prevent one stroke for every 200 people treated intensively, but you cause serious adverse events in an extra 2 people per 100 per year. Over 5 years, that's 10 serious adverse events for every stroke prevented. And remember, this was in a relatively healthy, younger population. Now think about what happens when we apply these intensive blood pressure targets to older adults, to people over 75, to people with diabetes who also have kidney disease, who have a history of falls, who have cognitive impairment, who are taking 8 or 10 other medications. The risk-benefit calculation changes completely. Let me explain 5 specific reasons why aggressive blood pressure control becomes more dangerous as we get older, especially when we have diabetes. Reason number 1 is called impaired autoregulation. Your brain needs a constant supply of blood to function. When you're young and healthy, your brain has this amazing ability to maintain constant blood flow even when your blood pressure changes. If your blood pressure drops when you stand up, the blood vessels in your brain automatically dilate to maintain flow. If your blood pressure spikes during exercise, the vessels constrict to protect your brain. This is called autoregulation, and it works beautifully when you're 35. But as we age, and especially when we have diabetes, this autoregulation system doesn't work as well. The blood vessels become stiffer. They lose their ability to respond quickly to changes in pressure. High blood sugar over years damages the small blood vessels in the brain. So when we push blood pressure down aggressively in an older adult with diabetes, their brain can't compensate. When they stand up and their blood pressure drops, their brain doesn't get enough blood. They feel dizzy, lightheaded, foggy, and sometimes they fall. This is exactly what happened to Margaret.
Reason number 2 is medication sensitivity. As we age, our bodies process medications differently. Our kidney function declines. On average, we lose about 1% of kidney function per year after age 40. Our liver function declines. We have less muscle mass and more fat tissue, which changes how drugs are distributed in our body. We produce less of the proteins that bind to medications in our blood. All of this means that the same dose of blood pressure medication that works perfectly in a 50-year-old might cause dangerous drops in blood pressure in a 75-year-old. And people with diabetes often have even more kidney impairment than people without diabetes, which makes this problem worse. Many of my patients are taking blood pressure medications at doses that would be appropriate for someone 20 years younger, simply because nobody recalculated the dose as they aged and their kidney function declined. Reason number 3 is what I call the cascade of adverse effects. Older adults with diabetes are rarely taking just 1 or 2 medications. The average 75-year-old with diabetes is taking 7 to 9 different medications: blood pressure medications, diabetes medications, cholesterol medications, maybe a blood thinner, maybe something for arthritis or heartburn or depression. And all of these medications interact with each other in ways we don't fully understand. When you add aggressive blood pressure control to this medication regimen, you increase the risk of what pharmacists call a prescribing cascade. The blood pressure medication causes dizziness, so the doctor prescribes something for dizziness. That medication causes constipation, so the doctor prescribes a laxative. The laxative causes dehydration, which makes the blood pressure drop even more. The water pill being used for blood pressure causes low potassium, so the doctor prescribes potassium supplements. The potassium supplements cause stomach upset, so the doctor prescribes something for that. You see how this spirals. Each medication creates a problem that requires another medication, and before long, the patient is taking 15 medications and feels terrible, all in pursuit of a blood pressure number that may not even be appropriate for their age and health status. Reason number 4 is the loss of warning symptoms. When you're younger, your body is really good at telling you when your blood sugar is low or when your blood pressure is dropping. You feel shaky, sweaty, your heart races. These warning signs give you time to sit down, drink some juice, take action. But as we age, and especially when we have diabetes, we lose these warning symptoms. This is partly due to a condition called autonomic neuropathy, where the nerves that control automatic body functions, like heart rate and blood pressure, get damaged by years of high blood sugar. So older adults with diabetes can have dangerous drops in blood pressure or blood sugar and not feel anything until they're already on the ground. Margaret didn't feel dizzy before she fell that first time. She just fell, no warning, and this is incredibly common in older adults with diabetes who are being treated with aggressive blood pressure targets. Reason number 5 is the frailty factor. Frailty is a medical term. It describes a state of decreased physiological reserve and increased vulnerability to stressors. It's not the same as being old. You can be 85 and not frail. You can be 70 and very frail. Frailty shows up as unintentional weight loss, exhaustion, weak grip strength, slow walking speed, low physical activity. And here's the key point. Frail older adults do not benefit from aggressive medical treatment the same way robust older adults do. In fact, aggressive treatment often harms them. A study published in the Journal of the American Geriatric Society in 2024 followed over 8,000 adults over 70 with diabetes and high blood pressure. They found that in patients who were frail, intensive blood pressure control with targets under 130/80 was associated with higher rates of falls, higher rates of hospitalization, higher rates of kidney injury, and no reduction in cardiovascular events. In other words, all harm and no benefit. The same study found that in robust, healthy older adults, intensive blood pressure control was associated with modest benefit and acceptable risk. So the question isn't, what's the right blood pressure target for older adults with diabetes? The question is, what's the right blood pressure target for this specific older adult with diabetes, taking into account their frailty status, their kidney function, their medication list, their fall risk, their cognitive function, and their personal goals and preferences. I need to pause here because I know some of you are feeling something right now. Maybe it's recognition, maybe it's fear, maybe it's relief that someone finally understands. So I'm going to ask you a question, and I really need you to answer it in the comments, not for me, but for the thousands of other people watching this who feel exactly like you do. Here's the question. Have you ever felt dizzy or lightheaded when standing up, especially in the morning after taking your blood pressure medication? If that's happened to you, I need you to comment these exact words: dizzy when standing. That's all, just those 3 words. And if you want to add how often it happens, daily, weekly, occasionally, please do. Because here's what I want you to understand. Every single comment that says dizzy when standing is going to be seen by someone else who thought they were the only one dealing with this. Someone who hasn't told their doctor because they think it's just part of getting older. Someone who's been afraid to admit that their medications make them feel worse. Your comment, those simple 3 words, might be the thing that makes another person realize they're not imagining it, they're not weak, and they need to talk to their doctor about their blood pressure target. So please, comment now, dizzy when standing. Let's break the silence around this together. I'll read every single comment, and in my next video, I'll address the patterns I see. Your voice matters here. Use it.
Now, let me tell you about a completely different patient. Someone the same age as Margaret, with the same diagnosis, but with a very different outcome. His name is James Patterson, and he was 77 years old when I met him 2 years ago. James also had type 2 diabetes for about 15 years. His A1C was 7.4%. He was taking metformin and insulin, and his blood pressure ran in the 145 to 150 over 80 to 85 range. James came to see me because his previous doctor had retired, and he needed a new endocrinologist. At our first visit, I asked James how he was feeling. He said he felt pretty good. He still worked part-time as a consultant, he played golf twice a week, he did his own yard work. He had good energy. His main complaint was that he was tired of taking so many pills, and he wanted to know if there was anything we could simplify. I looked at his medication list. He was taking 11 different medications. 3 of them were for blood pressure: amlodipine, lisinopril, and hydrochlorothiazide. His blood pressure in my office that day was 152 over 84. I asked him if he ever felt dizzy. He said no. I asked if he had ever fallen. He said no. I asked about his kidney function. His lab showed his kidney function was good for his age, with an estimated GFR of 58, which is stage 3A kidney disease, very common in people his age with diabetes. Then I asked James what his blood pressure goal was, and he said his previous doctor told him it should be under 130/80 because of his diabetes. So I asked him a different question. I asked him what was more important to him, hitting a specific blood pressure number or feeling good and maintaining his independence and active lifestyle. He looked at me like I was speaking a foreign language. He said, "Aren't those the same thing?" And I said, "Not always, not in older adults with diabetes." I explained to James the research I just explained to you. I told him about the Accord trial, about the risks and benefits, about how the targets that make sense for a 60-year-old might not make sense for a 77-year-old. I asked him about his goals. He said he wanted to see his grandchildren grow up. He wanted to keep playing golf. He wanted to stay out of the hospital. He did not want to end up in a nursing home. So I suggested we try something different. I suggested we stop one of his blood pressure medications, the water pill, and see what happened. James was nervous. He had been told for years that his blood pressure needed to be lower, but he trusted me, and he agreed to try. We stopped the water pill. I had him check his blood pressure at home twice a day for 2 weeks and send me the readings. His average blood pressure at home was 145/82, higher than the 130/80 goal, but not dangerously high. More importantly, James reported that he felt better. He wasn't getting up 3 times a night to urinate anymore. He had more energy during the day. He felt steady on his feet. We continued with this plan. I saw him every 3 months. We monitored his kidney function, which remained stable. We monitored his eyes with yearly exams, which showed only mild non-proliferative diabetic retinopathy, stable, not requiring treatment. We monitored his urine for protein, which was mildly elevated but not worsening, and we monitored how he felt and how he functioned. 2 years later, James is still playing golf twice a week. He still works part-time. He has not fallen. He has not been hospitalized. His blood pressure runs in the 140/150/80 to 85. His A1C is 7.2%, and he tells me he feels like he has his life back. Now, I need to be very clear. I am not saying we should never treat blood pressure in older adults with diabetes. I am not saying high blood pressure is safe. What I am saying is this: the target blood pressure, the number we are aiming for, must be individualized based on age, frailty, kidney function, medication burden, fall risk, and personal goals. James's blood pressure would be considered poorly controlled by conventional standards, but for James, at 77, active, independent, with no history of stroke or heart attack, it is exactly right. Now, let me give you another example, the other end of the spectrum. A woman named Dorothy Williams, 82 years old, diabetes for 20 years, blood pressure in the 165/175/90 to 95 range. Dorothy was frail. She had lost 20 pounds in the past year without trying. She walked with a walker. She had 2 falls in the past 6 months. Both required emergency room visits. She had moderate kidney disease, GFR of 35. She had mild cognitive impairment. Her daughter helped manage her medications. Her previous doctor wanted to push her blood pressure under 130/80, but her daughter was afraid the medications would make her fall more. When I evaluated Dorothy, I agreed with her daughter. Dorothy was too frail for aggressive blood pressure treatment, but I also knew blood pressure consistently over 160 systolic increases stroke risk significantly, even in very old adults. So we found a middle ground. We started one medication, low dose, single drug, target systolic pressure in the 140s or low 150s, not 130, not 160, somewhere in between. Over 6 months, her blood pressure averaged 148/86. Her daughter said Dorothy was steadier, she hadn't fallen, her kidney function stayed stable, and Dorothy told me she felt safe in her own home again. 3 patients, Margaret, James, Dorothy, all with diabetes, all with blood pressure above the conventional target, but each required a completely different plan. I know this is a lot, but this is why you need this channel. Guidelines change, research evolves, doctors are busy, and sometimes what they learned 10 years ago is no longer the best approach today. So what should your blood pressure target be? Here's how we break it down. For ages 65 to 75, healthy, no major kidney disease, no falls, no cognitive impairment, target systolic 130 to 140, diastolic under 90. For ages 75 to 85, robust 130 to 145, with some limitations 135 to 150. For adults over 85 or anyone who is frail, target systolic 140 to 150, avoid under 130, avoid over 160. Now I want you to comment your age, your average blood pressure, and your gut feeling. Use this format. 78 years old, average 125 over 75, too low. Or 71 years old, average 148 over 84, might be okay. Or 65 years old, average 155 over 90, needs to come down. This isn't just numbers. This is community. This is how people realize they are not alone. Now, here is your action plan. Step 1, track your blood pressure at home for 2 weeks, morning and evening, before food and medications. Write everything down. Step 2, track your symptoms, dizziness, fatigue, near falls, confusion. Step 3, assess frailty, weight loss, exhaustion, weakness, slow walking, low activity. Step 4, list your medications, especially blood pressure medications. Step 5, bring all this to your doctor and say, I want to discuss whether my blood pressure target is appropriate for my age and health. If your doctor is open, great. If not, seek a geriatrician or endocrinologist experienced with seniors. Now, let me tell you what happened to Margaret after she came to me. Her blood pressure was 148 over 86. She was on no blood pressure medications. I checked her blood pressure lying down, sitting, standing. Lying, 148 over 86. Sitting, 128 over 78. Standing, 102 over 68. That's orthostatic hypotension, a massive fall risk. So we did not treat her blood pressure. We treated her fall risk. Slow standing, calf pumps, hydration, compression stockings. 3 months later, her blood pressure averaged 145 over 84. She felt better. She started walking again. She started cooking again. She got her life back. 3 years later, she still hasn't fallen. No stroke, no heart attack, kidneys stable, eyes stable, quality of life restored. Before you go, remember this. The goal is not perfect numbers. The goal is a life worth living. Sometimes that means blood pressure in the 130s, sometimes the 140s, sometimes even the 150s. There is no single right answer, only the right answer for you. So comment one word, too low, perfect, or needs discussion, because your voice matters, your experience matters, and you deserve care that sees you as a person, not a number. And I want to leave you with this final thought. The purpose of treating blood pressure and diabetes is not to chase perfect numbers. It is not to satisfy a guideline. It is not to make a chart look good in your medical record. The purpose is to help you live longer and to help you live better. Sometimes those two goals go together. Lower numbers make you safer and healthier. But sometimes lower numbers make you weaker, more dizzy, more afraid, more likely to fall, more likely to end up in the hospital. And in those cases, Lower is not better. Lower is dangerous. Your job is not to be a good patient who blindly follows orders. Your job is to be a protected patient, an informed patient, a patient who understands the balance between safety and quality of life. Your doctor's job is to work with you, not against you, not over you, with you. If your current blood pressure treatment makes you feel dizzy, weak, confused, unsteady, afraid to move, afraid to stand, afraid to walk, then something is wrong. Even if your numbers look perfect, especially if your numbers look perfect, because perfect numbers should not cost you your independence. Perfect numbers should not cost you your confidence. Perfect numbers should not cost you your life. So I want you to promise yourself something today. Promise that you will not ignore symptoms anymore. Promise that you will not minimize how you feel. Promise that you will not accept fear as a normal part of aging. You deserve to feel safe in your own body. You deserve to trust your legs. You deserve to trust your mind. And you deserve medical care that protects all of that, not just a number on a cuff. If this video helped you even a little, subscribe to this channel, because this is what we do here. We translate medical research into real-life protection. We give you the information doctors often don't have time to explain. We help you ask better questions. We help you make safer decisions. We help you live better with diabetes and blood pressure. Turn on notifications, because the next video might answer the question you didn't even know you needed to ask. And before you leave, I want you to comment one of these 3 words: too low, perfect, or needs discussion. Just one word, that's all. Because when you write it, you acknowledge where you are. And when others read it, they realize they're not alone. Thank you for being here. Thank you for caring about your health. Thank you for refusing to be treated like a statistic. Your life matters. Your safety matters. Your voice matters. And I'll see you in the next video.